welcome. My name is Dr. Amar Jory, and it's my pleasure to present episode 4 for the JASE podcast. And it's my great honor today to have some guests. We're going to be talking about a paper from the June issue 2021 of the journal. And this particular issue has to deal with the condition known as pre-eclampsia, as well as ultrasound related to children who are born to mothers suffering from preeclampsia. So today it's my honor to have two guests. The first is Kiera Liblik. So I'm going to introduce Kiera. Hi, Kiera. How are you doing today?
I'm good. How are you?
Good. So Kiera, can you tell us a little bit about yourself?
Yeah, so I just completed my second year of medicine at Queen's University, and I'm now starting a master's in translational medicine here, looking at sociodemographic and cardiovascular risk factors that predict poor mental health outcomes in women following acute coronary syndrome.
Great. And why did you choose this paper to present to us today? What caught your interest?
Yeah, so it really plays to my interest in the intersection between women's health and cardiovascular health, as well as I had the pleasure of writing a review with Dr. Barr here about preeclampsia and how that's a risk factor for cardiovascular disease. So it seemed very fitting.
That's great. And Dr. Barr, thanks for joining us. It's really nice to have an expert in this area. Tell us a little bit about yourself and some of the research you've done in preeclampsia.
Yeah, absolutely. Thanks again, Dr. Joy and Kiera, for having me. So my graduate research is focused on the idea of preeclampsia as a set point for the trajectory for maternal and fetal or offspring cardiovascular disease. So I think that this paper by Hoodboy in 2021 really nicely encapsulates the mechanisms of preeclampsia as a mediator for long-term disease. It's a pleasure to be here.
Great. So we are going to ask you a little bit more about explaining preeclampsia to us. Would you like to do that now, you think, or a little bit near the end of the paper? What are your thoughts?
Absolutely, whatever fits in with Kiera's
presentation. Yeah. Why don't you tell us a little bit about it now, and then we'll go into Kiera's paper.
Yeah, absolutely. So preeclampsia is a fairly common complication of pregnancy that is characterized by new onset hypertension and proteinuria in the later stages of gestation. Now, we've known about preeclampsia for, cases of preeclampsia actually predate recorded time. So there are archaeological evidence of women dying of preeclampsia. So this is a disease that isn't new to the human race, but it is one whose etiology and outcomes we're still trying to untangle today. Part of the burgeoning research with preeclampsia has to do with how it may predispose both mother and child to cardiovascular disease. And great efforts are being expended right now to try and uncouple whether or not preeclampsia is an independent predictor of that, or if there is some sort of common antecedent to cardiovascular dysfunction that leads to disease.
Okay, that's great. And how do you define preeclampsia?
Absolutely. So the definition of preeclampsia does vary. There are regulatory bodies that agree on a tight set of clinical criteria, but typically it's new onset hypertension in pregnancy, proteinuria, and then there's a constellation of maternal symptoms, including neuropathic pain, upper right quadrant pain, and then there are also blood values that clinicians are trained to look for as an indicator of placental dysfunction.
Okay, and how significant is the problem?
That's a really great question. I think that it depends how you define the problem. In countries like Canada and the United States, maternal mortality due to preeclampsia is more rare. In the developing world and in areas where reproductive autonomy is still a work in progress, unfortunately, it carries a very high burden. But then when we consider the risks remote from pregnancy, I'd still say that it takes on a whole new dimensionality in terms of a problem, because we're finding out that there is an increased risk of mortality from a variety of different causes just because you've had the disorder. So I'd say it's both an acute and a distal problem when it comes to pregnancy.
Okay, great. Thanks, Dr. Barr, for that background information. I think that sets the scene nicely. Kiera, we'd love to hear your take on the paper now.
Yeah, absolutely. I'm just going to share my screen here. So today we're going to be talking about the paper Cardiovascular Dysfunction in Children Exposed to Preeclampsia During Fetal Life. So Logan gave a lovely background explaining preeclampsia, why it's important, and why we care about it, not even just in the short term for pregnancy complications, but why we also care about it in the long term, as it can be a cardiovascular risk factor, we know, in women and perhaps also in children. So we recognize that preeclampsia is an independent risk factor in women for early onset cardiovascular disease, although it's not currently recognized in most risk stratification tools. And we see this in a few longer term studies, but we know that, in fact, there's a 3.6-fold increase in cardiovascular death at age 60 for women who have been diagnosed with preeclampsia during pregnancy. Additionally, on the side of the fetus, we know that intrauterine growth restriction and perinatal death are higher in this group. And the aim of this specific study was now to look at if there are differences in cardiac and vascular structure and function in children who are exposed to preeclampsia in utero versus those who were born to normotensive mothers during pregnancy. So the study was a retrospective cohort study that was done in Pakistan. They included children who were 2 to 10 years of age. And the reason they chose this age group, on the upper end, 10 years old is just the cutoff for childhood as defined by the WHO. And on the lower end, the AHA has said that at 2 years old, you can start implementing a heart healthy diet in children who are at high risk of cardiovascular disease and have an impact on long-term cardiovascular outcomes. So they had balanced groups. There were 80 children in both groups. And then they also looked at cardiac structure and function using both conventional and deformation analysis, along with macrovascular function measured by blood pressure, carotid intermedia thickness, and pulse wave velocity. So this is just details of what they measured. So they looked at cardiac morphometry, systolic, diastolic function. They did some timing assessment and strain analysis. And then in terms of blood pressure, they looked at gender, age, and height-based blood pressure centiles as recommended by the American Academy of Pediatrics, because there was such an age range within the children. They went by centiles instead of just blood pressure values. So if we look at the demographic characteristics in this paper, there were 41% of the mothers with preeclampsia had early onset preeclampsia, which means before 34 weeks of gestation, and the other 59% late onset. Maternal age and BMI were significantly higher in the preeclampsia group, whereas gestational age of delivery and birth weight were lower. Sorry, the other way. Maternal age and BMI were higher, while gestational age at delivery and birth weight were lower in the preeclampsia group versus the non-preeclampsia group. Interestingly, cardiac morphometry did not vary between the groups. Neither did systolic, diastolic, and global function, or peak systolic global longitudinal strain analysis. So there were no significant differences in either cardiac shape or function parameters between the exposed and the unexposed groups. So that's women with preeclampsia who have had these children versus who haven't. And we can see that here if you go through any of their data. All of
Kiera, can I just clarify? That's the morphologic data for the women themselves. Is that correct?
No, this is for the children. So all of these measurements
okay.
were conducted on the children. Sorry.
Okay, got it. Thank you.
So there were no differences in cardiac morphometry. So we look at same with the systolic, diastolic function. Now, where we actually did see differences were in the blood pressure. So children in the who were born to preeclamptic mothers had a higher prevalence of stage 1 systolic and diastolic hypertension. So that's 22% had systolic hypertension and 35% diastolic, compared to the control group where there was only 9 and 19% respectively. And there were no children at all in the study with stage 2 hypertension, which essentially means that the recommendation is to do lifestyle intervention and then follow up instead of immediate medical management. So children in the preeclampsia group also had a slightly higher pulse wave velocity compared to those in the non-preeclamptic group, although this was not significant. So additionally, subgroup analysis was conducted to compare all cardiac and vascular outcomes between early and late stage onset preeclampsia compared with the unexposed group. And then what we could see was that in the difference in the blood pressure categories between the early and late onset preeclampsia group and the unexposed group, that the stage 1 systolic hypertension was significantly higher in the early and late onset groups when independently compared to the non-preeclamptic group, although stage 1 diastolic hypertension was only significantly higher in the late onset preeclampsia group. Additionally, there was a weak but statistically insignificant correlation of blood pressure and pulse wave velocity with the PE group. And there was no significant differences, again, in those cardiac outcomes, even when we separate the early and late onset preeclampsia and compare them to the control values. So overall, the findings of the study say that in this group of children aged 2 to 10, we saw that there was only differences in blood pressure. There was none in terms of the other parameters measured, although they did identify, and I think it'd be interesting for Logan to speak a little bit on this because this was his area of research, that they did not look at microvascular function, which may have had a role in the increased blood pressure that was seen in this. And this study is important because it's highlighting the fact that we may consider performing echo analysis on children, or blood pressure analysis on children who have had preeclamptic mothers at a young age to screen for cardiovascular risk.
That's great. Thanks, Kiera. Just a quick question. Can you clarify, were there any differences between CIMT between the groups, between the exposed and unexposed?
No, there were not.
Okay, great. All right, thank you for that great summary of the paper. Dr. Barr, it'd be wonderful to get your take on this. There weren't many echo differences, but there were some differences in blood pressure, and there was a trend towards increased pulse wave velocity. What are your thoughts on that? Is that what we had expected to find, and does that agree with some of the literature that's been published already?
Yeah, certainly, Dr. Jory. The intrauterine environment has been shown in long-term cohort studies to be a really powerful regulator of long-term cardiovascular function. Preeclampsia is certainly no exception. So the phenotype, the maternal phenotype of preeclampsia, namely anti-angiogenic factors, inflammation, sort of the pro-oxidative environment that the fetus is developing in, is now being understood as a mediator of long-term dysfunction. I'd say that this study really aligns with evidence that's emerging that suggests that PEF1s, so F1 generations exposed to preeclampsia, have subclinical dysregulation in vascular function. I believe there was another study that's come out recently that suggests that in male offspring, there is an increase in systolic blood pressure. Now, it doesn't, the insidious thing about this is that none of these children are clinically unhealthy. They don't have overt cardiovascular disease. This is what we would call a subclinical increase in these variables. But as we know, even a subclinical increase in these variables may alter the acceleration towards vascular pre-aging and cardiovascular disease.
Yes, it's quite interesting, and it makes me think about whether, you know, some of the trends towards vascular differences might become more manifest in this population later on. And it would be interesting to do further follow-up studies down the road and seeing if there are echo changes or further vascular changes down the road. Do you know of any work that's done longer term studies so far?
Well, yes, of course, serialized measurements are kind of the gold standard with this kind of research because we only see participants usually at one time point. I don't know of any off the top of my head that have been done in the offspring. I know that vascular functional measurements on a serialized basis have been done in moms, but I think that the literature in offspring is even more murky than it concerns moms that have had preeclampsia. But that's certainly a good idea for future study for sure.
Great, that's interesting. Kiera, you mentioned that you'd be interested in microvascular changes. Can you tell us a little bit more about what you meant by that?
Yeah, so actually Logan and I, or Dr. Barr and I, were having a discussion earlier today about it, as we had written that review on the cardiac and vascular changes associated with long-term preeclamptic outcomes in women. And he was talking a little bit about how they might be an explanation for us not seeing any echo changes in the study, but perhaps early microvascular changes. And interestingly, the study itself discussed a paper that was published, I think it was in 2016 in JAHA, looking at adolescence of children of women who'd had preeclampsia. And they had seen that they had greater relative wall thickness, reduced left ventricular and diastolic volume, and might have had early signs of concentric remodeling, which could affect cardiac function in the future. So it'd be interesting to see in the same now cohort of children who are showing a slight increase in blood pressure. Now as adolescents, will we actually see if there's any differences in, for example, concentric remodeling and signs of early cardiovascular disease?
That's quite interesting. Anything you'd like to add to that, Dr. Barr?
Yeah, Kiera raises a really good point. I think that there is sometimes siloing of cardiovascular investigation where either the cardiac changes are profiled or the microvascular changes are profiled. And we know that it's a continuum of dysfunction. And in a study like this, where there are no cardiac changes that we're seeing in this cohort, and no changes in CIMT, but an increase in pulse wave velocity, one thing that could augment these measurements are looking at the what we call outflow modulators, so the peripheral resistance, and whether or not there is measurable change that may explain the difficulties these individuals have with maintaining a healthy or a normal profile of systolic blood pressure.
Yes, that's great. Very interesting. So I think the purpose of this podcast is to not go into every detail of the paper. And I really appreciate Kiera highlighting the key points so that it gets our audience interested. And certainly our pediatric cardiologists might be interested in this work as well as others. So I'm really grateful to both of you guys for helping me go through this interesting paper. And I'm going to leave the last word to Kiera. Dr. Barr, thank you again so much for sharing your knowledge and putting this interesting paper in context. Kiera, if you can let us know what the reader should walk away from this paper, just summarizing the key points, and we will finish off there.
Yeah, absolutely. So I'd say the key point of this paper is that not only does preeclampsia have a profound effect on women and their cardiovascular health in the long term, but in fact might impact their offspring and long-term cardiovascular health. And I think what this really underscores is the importance of women's health and cardiology, and that it not only impacts women, which are such a huge and important part of our population, but also women's health in turn impacts the health of their children and their families, and that this is something that needs a lot more attention. And the fact that we are kind of sitting here postulating about it and not sure if it's macrovascular function and how this research is siloed really shows that we need to, I think, collaborate more in terms of integrating women's health into how we see cardiovascular disease and risk.
That's wonderful. Nicely put. Thank you so much, Kiera. And Dr. Barr, any last final comments from you?
No, I think Kiera summarized it perfectly. I think that we should move towards, increased integration of people who care about vascular health. And, I'm really excited about papers like these that hopefully will turn the tides of the extreme burden of preeclampsia on both mother and child.
Wonderful. Once again, this paper is available in the June issue 2021 of the Journal of the American Society of Echocardiography. Thank you for joining the podcast today. Thank you, Kiera. Thank you, Logan, for participating today. It was a great honor to have you on this episode. And I ask my audience members to tune next week for our continued weekly series of the JASE podcast. Thanks, everybody.